let's start discussion of the innermost layer of the eyeball. Innermost layer, as we all already know, is known as retina. So, innermost layer of the eyeball. Now, we just read that uvea, the middle layer, is the vascular layer. What about retina? What is the property of retina? Retina is known as the neural layer of the eye. Neural layer. It is called neural layer because it consists of nerve fibers. Retina, yes. All the nerve fibers in the retina will collect to form the optic nerve. Yes. So, if we try to basically understand what is retina, retina is the same as the film in the camera. If you have seen a roll of film that your father and mother used to use in their cameras of the old age, these days we use a SD card or an HD card. But that roll of film, what was the function of that? That it used to record the images. If the roll of film was damaged due to some reason, would the camera have been able to click any image, record any image? No. Similarly, if my retina is damaged, my eye cannot visualize anything. So, the basic function of retina is to record the image and then send it to the cortex via optic nerve. Are we clear, everybody? Now, when we want to discuss the anatomy of retina, the first thing that comes into our mind is discussion of layers of the retina. So, how many layers are there in the retina, guys? We have already said this. Yes? How many layers are there, everybody? 10 layers are there in the retina. But I am not going to discuss the layers of the retina right now. The names of the layers, the functions, the anatomy and all that, I will actually teach you when I teach you the chapter retina. It becomes easier to comprehend and remember there. So, what are we going to discuss here? We are going to discuss the gross anatomy. Gross anatomy meaning that when you look at the retina, what are the landmarks or the parts you are able to see? Am I clear, guys? So, let's start discussing the gross anatomy of the retina. So, on gross anatomy, we are able to see three parts of retina. What are those three parts? Number one, the first part, the most easily visible part, is known as optic disc, which is popularly also known as, all of us have read this during our first year anatomy classes, guys. Yes, very good, guys. Blind spot. Okay. So, optic disc also known as blind spot. Now, what is optic disc and why is it known as blind spot? That is what we need to understand. Okay. So, let's understand it by the use of an image. Everybody see this image on your screen, please. Now, we can see, everybody, that this is the optic nerve. Right? This is the outermost layer. Blue color is showing the middle layer and this red color is showing the innermost layer. The layer that we are discussing right now, retina. This is just a cut section of the eye like we have drawn already, guys. Okay. Now, this point, this circle that I have made, this is the point of retina from where the optic nerve is leaving the eyeball. Yes. So, this point is known as optic disc. The point in the retina from where the optic nerve leaves the eyeball. It will be visible as a circular or an oval shape and you will start calling it optic disc. Or what you can call optic disc. Actually, you can also call it the first part of optic nerve because ideally this is the point from where optic nerve is starting. So, the first part of the optic nerve, which is basically a part of the retina, the point where optic nerve leaves the eyeball, that is known as optic disc. Am I clear to everybody? So, let's write it. What is optic disc? Optic disc is the point from where optic nerve leaves the eyeball, or as I said, we can call it the first part of optic nerve. Am I clear to everybody? Yes? Now, why is it known as blind spot? That's the second question which should come into your mind. So, everybody, we know, this much we know, yes, that vision is given by two types of cells in the retina. One is rod cell, the other is cone cell. Why is it known as blind spot? Because the point where optic disc is formed, rods and cones are absent. There are only nerve fibers. Optic disc is a part of optic nerve. Optic nerve does not consist of rods and cones. Optic nerve consists of only nerve fibers. Yes. So it is known as blind spot because rods and cones are absent here. So because rods and cones are absent here, there will be no image formation. There will be no vision here. So that is why blind spot. Simple, guys. Now, this is the first part that we are able to see. The second thing that we should be able to see if we look carefully is macula. Macula, guys. Or if you don't know macula, then I will ask you what is the center of macula known as? Yes, I am hearing a lot of answers. I know all of us know this. Center of macula is known as fovea. Yes. So to understand, you can either remember macula or fovea. That is the part that we are trying to see now. Now, why are we trying to see this? What is the importance of this? So again, all of us should know, all of us know, I hope, that fovea contains maximum concentration of cones. Fovea contains the maximum concentration of cones. Because it contains the maximum concentration of cones, try to think of it like this, that all of the cones which are present will be nearer to each other. Yes? If they are nearer to each other, they will give you a clearer image. Compare it to the pixels on your mobile. The old age mobiles that used to come, they had a resolution of 720 pixels. So that means the point of image formed was further away from each other. But these days we have 4K or what you call as 1920 pixels, something like that. So the pixels are closer to each other and that is why you get a sharper resolution. So similarly, because the concentration of cones is maximum at fovea, because the cones are nearer to each other, so there are more pixels, you can say. So the image you get is sharper and the clearest image that you get at the retina. Okay. So I will say loosely that this gives you the best image as it is most sensitive to light. Am I clear, everybody? With the understanding of the mobile screen, I hope you will be able to remember it. Okay. Now, why does it become important to see this part? It becomes important to see this part because if you understand, this is giving us the best image. So, now to explain it to you, if I ask you, if I divide my vision or visual field into two parts, this is my central visual field, yes? Whereas this part here, everybody, this is my peripheral visual field. Which visual field are we using most of the times? Are we using our central vision or are we using our peripheral vision? I hope this answer is very clear. Peripheral vision we don't use actually. We are most of the times using our central vision only. Peripheral vision we use only in certain cases, kind of activities. When you're driving a car, that is when your peripheral vision comes into account. Or let's say when you want to cheat in an exam, then that is when you need to look at the periphery, yes? So peripheral vision per se is not that important. Even if it is lost, you can carry out your day-to-day activities. But if your central vision gets affected, you will come running to an ophthalmologist saying, sir, I have loss of vision. I hope you understand that. So basically this macula or fovea, whatever we have said here, if I say in one word, this is responsible for our central vision. Am I clear, everybody? Now, if it is responsible for central vision, when I teach you retina, I'll teach you a disease or lots of diseases of macula. Let's say I give you an example. There will be a disease called as CME, cystoid macular edema. And if I ask you what is the clinical feature of cystoid macular edema, you don't need to imagine anymore. You just need to go back to anatomy, that the disease is at the macula. Macula is giving you central vision. So the symptom will be loss of central vision. In all macular diseases, the symptom will be loss of central vision. I hope we are clear about this. That's the second part, guys. Moving on to the third part. The third part of the retina, gross anatomy that you can see is known as ora serrata. Now, this is something a lot of students have not heard. Optic disc and macula we usually hear if we have read even a little bit of ophthalmology. Ora serrata. Okay, let's see what is ora serrata. So everybody, let's get back to this image. Okay. Again, here we can see this red colored line or this red colored part in this cut section is the retina. If we see carefully, retina is forming the posterior, or it is covering the posterior part of the eyeball, but the retina ends at this point. The retina ends at this point. So I can say retina is basically an incomplete layer. Covers eye only posteriorly. Covers the eye only posteriorly. Am I clear to everybody? See, the outer layer will cover the whole eye. The middle layer will cover the whole eye, anterior to posterior. But the retina is only a posterior layer. So this point, everybody, that we have marked here, the point where retina is terminating. Am I clear again? See, look at my hand, everybody, if you are confused. If you are looking at my eye, this is my retina. My retina is covering the posterior part of the eyeball, but at this point it is ending. It is not present anteriorly. So this point where my retina terminates or ends will be called as ora serrata, the point of anterior termination of retina. Okay? Now, if you understand this, there is another way of defining ora serrata. Okay? Let's say I draw a perpendicular line from ora serrata. Everybody? Now, if we see it in relation to the middle layer uvea, we can see that this perpendicular line from ora serrata is cutting uvea into two parts. Yes, the part anterior to the ora serrata is ciliary body, and the part posterior to ora serrata is the choroid. Am I clear? So ora serrata, even though it is a part of retina, I can use it as a landmark and call it the junction between ciliary body anteriorly and choroid posteriorly. Done, everybody? So two ways to define ora serrata. Now let's write this. So what is ora serrata, guys? So ora serrata is anterior termination of retina. Anterior termination of retina, or as I just explained, junction between ciliary body and choroid. Junction between ciliary body and choroid. Okay? Now we know what is ora serrata. But the point again comes, just like limbus. Retina was ending, let it end, yaar. My finger ends here. Do I give this thing a point? Do I call it a name? My hairs or the lack of hair, they end here. Do I call it a name? No. So why am I giving the termination of retina a name? Because it must have some clinical significance. So let's try to understand what is the clinical significance, what is the anatomical, surgical importance of ora serrata. Everybody, again let's look at this image. In this I will again mark ora serrata for you. So this is my ora serrata. I'm just writing OS. Then if I look at this point, this is the outermost layer, everybody. So I hope you are able to understand which point I have marked. This will be cornea. Behind this will be sclera. So this point is limbus, right? So ora serrata and limbus, two landmarks I have marked for you. Now I am writing a word. Intravitreal injection. Intravitreal injection. We've already read the routes of ocular drug administration, in which point number 4 was intravitreal. Yes. So now what we want to discuss is what is the site of intravitreal injection. That means if you need to give the drug inside the vitreous, from where do you enter the eye? Okay. So everybody, we know that behind, or we should know if we don't, everybody, that behind the lens, this whole area which is visible in yellow color in this image is your vitreous. Now we need to inject a drug inside the vitreous, in the vitreous cavity. Okay. So where do we pierce the eyeball and go inside? I will give you 3 options, guys. Option number 1. I take a syringe and I pierce the eyeball from here. I will call it number 1. From here means, if I say it anatomically, I am going posterior to ora serrata. Okay. Point number 2, or site number 2, I go from here. What will I call this, everybody? Anterior to ora serrata. Yes or no? Now I am going anterior to ora serrata. Or I can say actually I am going posterior to limbus. Ora serrata ke anterior, but limbus ke posterior. Done? Or third, simplest, guys. Just poke the eye from the anterior most part. Yes. Now, if you have these three options being given to you, which one will you like to choose? Number 1, number 2 or number 3? Common sense answer, guys. I hope there is nothing much to explain here. Will you choose number 1? Will you choose number 1? No? Okay, no. But why no? Why no? Because if you are going from point number 1, posterior to ora serrata, you are also damaging the retina. You are creating a hole in the retina. If you are creating a hole in the retina, you are damaging the film of your camera, and your film of your camera will not be able to record vision. Okay, guys? I hope nobody will like to go from number 3. You won't like to puncture the eye. Basically, you won't like to puncture the cornea and the lens and everything. That should be very basic. So what is our site of intravitreal injection, guys? Number 2. Okay. So how can we say site of intravitreal injection? Again, sir, there are various ways of saying it. Number 1, we said it is anterior to ora serrata. Number 2, we said it is posterior to limbus. Or if I just say it in another language, it is between limbus and ora serrata. Yes, between limbus and ora serrata. Okay, everybody? So let's write site of intravitreal injection. It can be called as A, anterior to ora serrata, or B, posterior to limbus, or C, between ora serrata and limbus. Okay, self-explanatory if you understand the anatomical diagram on your screen. Okay, guys? Waiting for you to just write your notes. Then you will see I have mentioned D. Is there another way to say the site of intravitreal injection? Yes, ideally there is. Let's understand this. When I am going inside, everybody, when I am piercing the eye, the examiners will like to ask you to give an intravitreal injection. Actually, you are piercing which structure of the eyeball? So let's move from outside to inside. First of all, the outermost layer. Which part of the outermost layer are you piercing? Are you piercing the cornea? No, cornea is anterior to limbus. But you have gone posterior to limbus. If you have gone posterior to limbus, what is this part that you have pierced? You have pierced the sclera. Are we clear? Then, what is the part of the middle layer that you have pierced? You have gone anterior to ora serrata. As we just now discussed, ora serrata ke anterior, what will be there? Ciliary body, because it is the junction between ciliary body and choroid. So you have pierced ciliary body. But which part of ciliary body? Pars plicator or pars plana? Think about it. Again, you already know the answer if you are focusing in the class. If you are concentrating on the lecture, you know the answer. Will I pierce pars plicator or will I pierce pars plana, and why? Yes, very good, guys. I will pierce pars plana. Why am I piercing pars plana? Because I have already told you it is relatively avascular. Out of all the parts of the uvea, it is the most avascular part. So when we go in, we don't want bleeding too much. So we choose pars plana as the piercing site. So the last answer is by piercing sclera and pars plana. So to give a vitreous structure, to give a intravitreal injection, we only need to pierce two structures: outermost layer sclera, middle layer pars plana. Right, guys? So this answer can be done in 4 ways. Please remember, the examiners can twist English in any way. That's why I've tried to tell you always that the answer can be done. I hope you comprehend this. I hope you remember this. Nothing difficult. Okay? Now, let's try to understand further. Let me show you another image. Let's see this image, everybody. So now this is what you will actually see in the eye. You won't see a cut section. Yes? If you are looking at a patient, this is what you are seeing. So what you can see, everybody, that this is your cornea. So this point, everybody, this point becomes your limbus, corneoscleral junction. We have already discussed the outermost layer. I hope you understand this. Nothing difficult now. Black and white junction. Now, this I have told you, or I have marked here, that this is the ora serrata. This image shows you that the distance between the limbus and the ora serrata is approximately 6 mm. Distance between the 2 points, limbus and ora serrata, is approximately 6 mm. To give the intravitreal injection, we need to go between the limbus and ora serrata. So the question comes into my mind, or you can ask me rather, or you will ask me if you are in a posting. Sir, if the distance is 6 mm, where should I go in from? Should I go 1 mm, 2 mm, 3 mm, 4 mm, 5 mm, 5.5 mm? Where should I go? 6 mm is a large distance for the eye. Yes? So what is the exact site or appropriate site for intravitreal injection? Let's see, everybody. appropriate site of intravitreal injection. I have written short form IVT. Please don't write IV injection for intravitreal. The paramedical staff may confuse it to be intravenous. So please, okay. Appropriate site of IVT injection. A. 3 mm posterior to limbus. If aphakia. Okay. Second point, 3.5 mm posterior to limbus if pseudophakia. So basically, if you understand from these 2 points, the exact or appropriate distance of injection will change according to the status of the lens. Okay, everybody? If you don't know what is aphakia, please remember phakia is a word, or phaco, phaca, whatever. This word will always be used for lens. Aphakia will mean absence of lens. Done? What do you mean by pseudophakia? Very abundantly clear. Pseudo means false lens. But what do you mean by false lens? After cataract surgery, we implant an artificial lens, yes or no? We say cataract surgery ke baad nakli lens dalenge, yes? So that is false lens. Or I can say presence of IOL, intraocular lens. Okay, everybody? So we know if there is aphakia, the distance will be 3 mm. If it is pseudophakia, the distance will be 3.5 mm. But what about phakia? 4 mm posterior to limbus if phakia. Phakia means normal crystalline lens. The lens that has been given to us by God, guys, basically, to understand in very crude language. Okay, so the normal crystalline lens that is present in our eye, if we are about to give an intravitreal injection, then the distance has to be 4 mm posterior to limbus. Okay, guys, clear about it? So please remember, first of all, the site of intravitreal injection as a whole, and then if you are given the status of the lens, the distance will change. So the answer is 3 to 4 mm, 3.5 or 4 mm. I hope we are absolutely clear about it. Okay, everybody, done? Now the question comes in my mind, what I want to ask you, why have I written all the distances posterior to limbus? I didn't write anything anterior to ora serrata. I have written everything posterior to limbus. Why, guys? Think about it. Clinically, think about it. Think about it clinically. There are 2 landmarks. One is limbus, one is ora serrata. But clinically, I am using all distances from limbus. Why, guys? Why? Yes, very good. Can you see limbus in my eye? Yes, you can see limbus in my eye. But can you see ora serrata in my eye? No. Limbus is a landmark of the outermost layer, so it is visible. But ora serrata, you can't see retina, you can't see ora serrata. So clinically, to give an injection, you use limbus as a landmark and not ora serrata. Hello everyone. This is a video on how to give an intravitreal injection. Please note at the beginning that the surgeon is holding an eye speculum in his left hand, whereas in his right hand, the surgeon is holding a cotton tip which has been dipped into betadine to act as a sterilizing agent. Now, as step 1, to have a clear field of view, the eyelid is being opened with the help of the eye speculum. That is what you will be able to see. And you are able to see that in the infratemporal region, the surgeon is just sterilizing the sclera with his cotton tip. Now we ask the patient to look up and in to get a clear view infratemporally, and with the caliper open to the desired distance, we are marking a point, and that will be the point of our injection. Now we see that the surgeon has taken a 1 ml syringe with a 30 gauge needle, and through the point which was marked earlier, the surgeon is making slow twisting movements to go through the sclera, and finally we have been able to inject the drug inside the vitreous. Right, guys? So this is how we give an intravitreal injection. Limbus will be used as a landmark. This is very easy, guys. If you understand, anybody can give it. If you're an intern, you can give it. All you need to know is the theory, guys. Okay? So theory is obviously important to be able to practice the clinicals. That's it about the anatomy of the innermost layer of the eyeball. We have discussed three parts: optic disc, macula, and ora serrata. So with this, basically, we have discussed the anatomy of all the three layers of the eyeball. If you go back to the orange, everybody, we have discussed the outermost layer, we have discussed the middle layer, and we have discussed the innermost layer. If you have realized, even though I have again and again said it is the basic anatomy, but these basics are something, if we don't know, it is difficult to understand a lot of conditions that we will have to discuss in each of the chapter 4 with. And also, there are thousands of MCQs that can be asked from this. So this is not something which you are reading only for your understanding. If you are just a MCQ oriented student, then please remember I have taught you important concepts here. Each piece of information can be asked. A simple question was asked in AIMS 2020 exam this year based on what is true about cornea, that the epithelium is stratified, that the Bowman's layer cannot regenerate, blah, blah, blah. Right, guys? So questions are asked. Questions are asked on accommodation. Questions are asked on intravitreal injection. Questions are asked on routes of drug administration. Questions are asked on episcleritis, scleritis. Questions are asked from all this that I have told you. So please don't miss it. Again, as I'll say, basics are important. If you don't understand the basics, try to spend more time in it. That will make your subject much easier to remember. So to summarize the anatomy of the eye for all of you guys, I can actually make you remember the anatomy of the eye in your hands. Okay? Whenever you want to visualize the eyeball, always hold out your hands like this. Everybody, look at my hands. What can you see, everybody? What is this? Just remember the diagram. Yes, this is your iris. In the center, there is an aperture. That will be your pupil. What is this, everybody? These are your ciliary processes. So what is this being shown? This is your pars plicatum. Then see this part, everybody. This part of my hand, which is without the shirt. This is your pars plana. So basically what I'm trying to show you here is the middle layer of the eyeball. Again, iris, pars plicatum, pars plana. And then all this shirt that you see, everybody going back, everybody, this becomes your choroid. So this is my middle layer in my hand. If you know your middle layer, then try to imagine. If this is iris, in front of the iris, what will be there, everybody? Cornea. Then behind this, everybody, what will be there? Your sclera. Okay? Again, hold your hands. We already know that ora serrata is the junction between choroid and ciliary body. That means at this point where my shirt is starting, this will be ora serrata for retina. So my whole shirt will be covered by an inner layer that will be my retina. Okay? This is my ciliary processes. From ciliary processes start my zonules. So let's imagine that this thumb of mine is ciliary zonules. And then in between there will be lens. Are you getting my point? So this is just an easy way to remember. Whenever in doubt, just hold out your hand, just see it like this, just revise it mentally a lot of times. And as I say, you will have your eye in your arms. Girlfriend or boyfriend, I don't know. But yes, your eye certainly can be in your arms, guys. Okay, let's start with another simple topic in anatomy, that is spaces inside the eyeball. Nothing difficult, guys, very basic. Let's just try to see whether you know it or not. Spaces in eyeball. I'll draw cut section as I always draw. Cornea, limbus, sclera, optic nerve, iris, lens. Just a simplified diagram of the cut section, having only the parts that are important to me. Now, if I see this cut section, I have actually three spaces inside the eye. Space number 1, space number 2, and space number 3. Okay? Now, I know all of you must be saying that this is something which is very easy. I know it is very easy. So, what is space number 1 known as? That's my question. It is easy. You should be able to answer. What is space number 1 known as? If you're saying vitreous, I'm not asking you what is present inside space number 1. I'm asking you the name of space number 1. Taj Mahal is present in Agra. I'm asking you whether this space is Agra or Delhi. I'm not asking you Qutub Minar or Taj Mahal, guys. Okay? So what is space number 1 known as? Yes, posterior chamber. If you are saying posterior chamber, then your basics are weak, guys. This is not posterior chamber. Aqueous is present in posterior chamber. Vitreous is not present in posterior chamber. This is posterior segment. Posterior segment contains vitreous. This is a very simple fact, but as I have come to know that a lot of students, when they pass their third year, they somehow have this fundamental confused. Okay, guys? So space number 1, known as posterior segment of the eye, contains vitreous or vitreous cavity. Okay. Now what is space number 2 known as, guys? I hope now this will be very easy. Space number 2, the space between iris and lens, is known as, yes, this is your posterior chamber. Then what will be space number 3, guys? Space number 3, the space between cornea and iris, this is known as anterior chamber. Posterior chamber, anterior chamber, both are together known as, if you add both of these are together known as anterior segment. These are together known as anterior segment. And what does the anterior segment contain, guys? Anterior segment meaning anterior chamber, posterior chamber, all of these contain aqueous. Okay, guys? So we can say basically that the lens is the dividing point. In front of the lens, everything is aqueous. All this is aqueous. And behind the lens, all this is vitreous. Okay, everybody? The nomenclature is important here. I have drawn this diagram. I have taken these 5 minutes just to make you understand that posterior chamber does not contain vitreous. Posterior segment contains vitreous. This is your basically of glaucoma. When you study glaucoma, glaucoma is a condition which is somewhere related to aqueous. So that means the problem may be in anterior chamber and posterior chamber, because anterior chamber and posterior chamber both contain aqueous. Right, guys? Now that we've written these two words on the screen, aqueous and vitreous, let's discuss some basic differences between both aqueous and vitreous. My first question about aqueous to all of you. Aqueous is what state? Solid, liquid, gas? We already know aqueous means aqua means liquid. So aqueous is in liquid state. But what about vitreous, guys? What about vitreous? Vitreous, is it in liquid state? Is vitreous in liquid state? The answer is no. Vitreous is in gel form or gel state. Why? Because it contains hyaluronic acid, glycosaminoglycan hyaluronic acid, which converts or which makes it a gel. Done, everybody? Now, second question, very basic simple question that they can ask you is, what is the volume of aqueous? So the volume of aqueous is very small, only 0.31 ml. Okay. Now, aqueous is present in two parts or two spaces. So what is the volume in anterior chamber? And what is the volume in posterior chamber? In anterior chamber, we say the volume is 0.25 ml. So doing simple maths, the volume in posterior chamber will be 0.06 ml. But what about the volume of vitreous? If you realize from all the images or all the cut sections that we have drawn, the vitreous cavity is always much larger than the aqueous cavity or the anterior segment. Yes, the volume of vitreous is approximately 4 ml. The volume of vitreous is approximately 4 ml. Moving forward, guys. Okay, so aqueous. Again, we already know fact about aqueous. Aqueous is continuously secreted by ciliary processes. Remember the cow, I hope, everybody? Yes. So aqueous is secreted by ciliary processes. If it is being secreted, the question the examiners will ask you is, what is the rate of secretion? What is the rate of secretion? The answer is 2.3 microliter per minute. Okay. What about vitreous? Is vitreous also continuously secreted or continuously formed? No. Vitreous is formed only during development of the eye. So it is not continuously formed. So it is not continuously formed. Now, Let's talk about aqueous now. We are saying aqueous has a rate of secretion. So aqueous is continuously secreted inside the eye. So basically there is a liquid which is entering the eye. Can the liquid keep on collecting inside the eye? Obviously not, yaar. The eye has a certain volume, certain pressure it can hold. If the liquid is coming inside, it simply needs to go outside also. So just like there is a secretion, there is an outflow. Okay. The secretion is from ciliary processes, but the outflow is from trabecular meshwork. Okay. Obviously we'll discuss that in much more detail in glaucoma chapter. But what I'm trying to say here is, just like there is a rate of secretion inside the eye, there is a rate of outside the eye secretion also, or outflow also. We call it facility of aqueous outflow, which is denoted as C value. Facility of aqueous outflow. So the facility of aqueous outflow, guys, is 0.18 to 0.25 microliter per minute. Okay, guys, this is C value. Now, apart from the fact that what is C value, the numerical value and the aqueous outflow it denotes, they can ask you which investigation is done to measure the C value. Which investigation is done to measure the C value? This is something that we usually don't study, guys. So this is known as tono. Did you say tonometry? Did you think you already know this? No, guys, the answer is not tonometry. The answer is tonography. The investigation done to measure the C value is tonography, not tonometry, guys. So what is tonometry? Yes. So what is the function of aqueous, guys? Apart from providing nutrition and everything else, aqueous exerts IOP, intraocular pressure. Yes, I'm writing both the words together so that you never have a problem understanding this. Now, which investigation is done to measure the intraocular pressure, IOP? Now the answer is what all of you were giving probably at your homes, tonometry. Okay, guys? So tonography, tonometry, two confusing words. Please do remember them. Tonometry, the more popular word, used to measure the intraocular pressure, and tonography for something called as C value, outflow of aqueous. Now, after we know this, let's discuss just some 2 or 3 more points about the aqueous in the anterior chamber, guys. Anterior chamber depth. I'm discussing it here because anterior chamber contains aqueous. So as part of your notes for aqueous, we are writing this. Anterior chamber depth, normally 2.5 to 4.4 mm. Normally 2.5 to 4.4 mm. It is increased in. I'm not discussing pathological conditions here. I'm just discussing physiological variations. Okay. It is increased in. I like to remember it as my, my. What does my become? My for myopes, people who are myopic. Which sex, everybody? Male. And which age group, guys? Young. Okay. So young males who are myopes will have increased anterior chamber depth. Just one last fact about aqueous, guys. Aqueous contains higher concentrations of LAP, lactate, ascorbate, and pyruvate, obviously, than plasma. We are comparing everything to plasma, guys, in these terms. So aqueous contains higher concentration of LAP, lactate, ascorbate, and pyruvate than plasma. Okay. So just some simple fact-based questions, guys, about aqueous and vitreous. I don't think there should be any confusion in this. Nothing difficult to understand, or nothing difficult, or rather nothing to understand, I can say here. Right, guys? Done. That's all about species of the eyeball from my side. And with this, I finished now the layers and the species both. To finish the basic anatomy of the eye, we will be discussing the blood supply of the eye, and then we will be moving on to our topics per se. Okay, guys? So let's begin our next topic, that is blood supply of the eye. When we start this topic, the first thing that we should think about is the eye is an organ. Gets its supply from the external carotid system of arteries or the internal carotid system of artery? That's the main thing. So yes, the answer here is internal carotid artery. All the blood supply to the eye comes from internal carotid artery. Now, which branch of internal carotid artery? What is the first branch of internal carotid artery? Very good, guys. Ophthalmic artery. The name itself is making it clear that ophthalmic artery means it is supplying my eye. Yes. So now all the blood supply is branches of ophthalmic artery. So ophthalmic artery is giving us three main branches. The first branch, central retinal artery. Then we have posterior ciliary artery. And then third, muscular branches. Okay. So we have a tripod of supply basically. Central retinal, posterior ciliary and muscular branches. Let's talk about each of these arteries one by one. Very simple, guys, nothing difficult. Central retinal artery is the easiest. By the name itself, it is telling us that I am supplying the retina. But does it supply all the retina? When I say all the retina, does it supply all the 10 layers of the retina? The answer is no. Central retinal artery travels within the optic nerve and supplies the inner 6 layers of retina. Inner 6 layers of retina. Okay, guys? Now, done. Now move on to the next, posterior ciliary artery. So posterior ciliary artery, guys, gives two further branches. Long posterior ciliary artery and short posterior ciliary artery. Long posterior ciliary artery, short posterior ciliary artery. Long posterior ciliary arteries are 2 in number, but short posterior ciliary arteries are around 20 in number. Okay? Now, let's first discuss short posterior ciliary artery. Short posterior ciliary arteries, they enter the eye by piercing around optic nerve. They enter the eye by piercing around the optic nerve. What do we mean by this? Very simple, guys. If this is my eye, this is my optic nerve. Okay? So all the arteries will pierce just around the optic nerve. Okay? If this, my finger is my optic nerve. So let's say you are shooting around the optic nerve, like they show in those movies, that you are not hitting the person, you are just making a outline of the person. Yes. So we are making 20 bullets around the optic nerve. Okay. So all around the optic nerve, there are 20 openings. Okay. Now, when they enter the eye around the optic nerve, they supply sclera. They are piercing the sclera. Okay. I will just write enter the eye by piercing sclera around the optic nerve, obviously. So they are supplying the sclera. Then after the sclera, there is what, everybody? Sclera is the outermost layer. Then below sclera will be what? Middle layer. Middle layer, which part? Posterior part, choroid. So they will supply choroid. And they will also supply, now inside the choroid there is what, everybody? Retina. Which layers of retina are left, everybody? The layers of retina which are touching the choroid. Outer 4 layers of the retina. Are you able to understand this? The inner 6 layers of the retina were supplied by the central retinal artery, but the outer face which touches the choroid is still not supplied. That gets supplied by short posterior ciliary artery. So everything posteriorly, basically, everybody, if you try to see the eye from posterior part, first the sclera, then the choroid, then the outer 4 layers of the retina, gets supplied by short posterior ciliary artery. I hope you are able to imagine. I hope you are able to open your arms and imagine this. पहले sclera, फिर choroid, फिर outer 4 layers of the retina, supplied by short posterior ciliary artery. Now understand the nomenclature. If you focus on the nomenclature, you will yourself be able to remember. The name itself is self-explanatory. Short posterior ciliary artery. If you focus on the name, the blood vessels are coming from the posterior side. So it is called posterior ciliary artery. And its course is very short. It comes from posterior side and it supplies all the posterior part of the eye. So that is why short posterior ciliary artery. Okay. Now let's move on to the other branch, long posterior ciliary artery. Long posterior ciliary artery will enter the eye by piercing sclera away from optic nerve. Okay. That means the point where long posterior ciliary artery will pierce the sclera will be slightly away from, or will have some distance from the optic nerve. After piercing, it travels between sclera and choroid, reaches up to the ciliary body and divides into 2 branches. Okay. So it has pierced the sclera. Now it has a long course. Focus on the name, long posterior. So it is traveling between the sclera and the choroid. It is going forward, 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 forward. Yes, it has passed all the choroid. Now it has reached the ciliary body. In the ciliary body, it is dividing into 2 branches. These 2 branches supply the ciliary muscle. These 2 branches supply the ciliary muscle. Okay? Am I clear? Ciliary body contains ciliary muscle. Then everybody, these 2 branches will go further forward. And will reach the iris, the periphery of the iris. In the periphery of the iris, they will anastomose from the left side and the right side, and they will form a circle. Can you understand? They will anastomose and they will form a circle. These 2 branches anastomose near the root of iris, the periphery, to form major arterial circle of iris. It's a big circle. That's why it's called major arterial circle of iris. And obviously it will supply the periphery of iris. Okay. Then, from this major arterial circle, branches of major arterial circle move centrally and form minor arterial circle of iris. Branches of the major arterial circle, a lot of branches will come centrally. When they come central, they will come towards the center of the iris. Center of the iris means pupil, everybody. So basically around the pupillary margin, they will form a smaller circle that will be called as minor arterial circle of iris, and this will supply the pupillary margin. No brainer, guys. Okay, this will supply the pupillary margin and some of the central part of the iris. Am I clear, everybody? So it is a long course. I hope you understand this. That this artery has a long course. It comes posteriorly. Then it travels up to the intermediate part, ciliary body. Then it also travels right up to the pupil, that is the anterior part. Because it has such a long course, that is why this artery gets named as long posterior ciliary artery. And it is supplying what, everybody? Ciliary body and the iris as a whole. So the two parts of uvea which were left, choroid was already supplied by the short posterior ciliary artery. The two parts which were left, ciliary body and the iris, are being supplied by long posterior ciliary artery. Please remember the two words, major arterial circle and minor arterial circle. Just fancy words, nothing in terms of substance to these words. Okay, guys, done? So that's all about our second branch, posterior ciliary artery. Now we move on to the third branch of the ophthalmic artery, and let's see what does it supply. Moving back up, guys. So the third branch was muscular branches from ophthalmic artery. How many muscular branches are there? That's the first question. So there are total 7 muscular branches. 2 each from superior rectus, medial rectus, inferior rectus, and 1 from lateral rectus. That is the question that the examiners will look for. 1 from lateral rectus. That all the recti give 2 branches each, but the lateral recti gives only a single branch. These branches, all these muscular branches, they form anterior ciliary arteries which pierce sclera 5 mm posterior to limbus, which pierce the sclera 5 mm posterior to limbus. See, focus. The name is anterior ciliary artery. That's why I'm using an anterior landmark now. I'm no more saying optic nerve near or around or away. I'm using an anterior landmark limbus. So posterior to limbus 5 mm, they pierce the sclera, and then they will supply what, everybody? They supply conjunctiva. Main thing, guys, they supply conjunctiva, anterior part of sclera, and some part of iris and ciliary body. The main thing is conjunctiva, everybody. Okay? Do we understand? So all the anterior structures, conjunctiva, then sclera, then some part of ciliary body and some part of iris, they are supplied by the muscular branches. 7 muscular branches. Please remember, 1 comes from lateral recti and 2 each come from superior, middle and inferior recti, and they together form the anterior ciliary arteries. Done, guys? So that's a brief explanation of the blood supply to the eye, internal carotid artery system, ophthalmic artery, 3 branches, central retinal, posterior ciliary and muscular branches. Now that we know the theory, I hope we are good enough to identify these in an image. So that's your culmination of the blood supply to the eye. If you have been able to understand it, comprehend it, then you will be able to identify all the arteries in the image that I show you next. So this is the image, guys. Right? Now, in this image, you will see 6 arteries marked on the screen. Let's try to identify each one of them. Let's start with number 1. What is this? Try to see, everybody. What is this? See, this is an artery which is dividing into 3 branches. Number 1, number 2, number 3 here. So this must be your ophthalmic artery. Okay? Now, let's move on to number 2. This artery, everybody. Let's trace it back. This artery is traveling within the optic nerve. Can you see, everybody? That's the clue. This artery is traveling within the optic nerve. If it is traveling within the optic nerve, it must be, everybody focus on your theory if you remember it, central retinal artery. Am I clear? So each artery has a clue. Now, let's see artery number 3. Okay, number 3, everybody. Let's see here everybody. Number 3, this artery. This artery. How to identify this artery everybody? Let's move forward. If we move forward, we see it is further dividing into 2 branches. That's the clue. If an artery is further dividing into 2 branches, it can only be posterior ciliary artery, which is dividing into long posterior and short posterior. So posterior ciliary artery. Now, number 4. Number 4 artery. Number 4 artery, as we can see, is a division of the posterior ciliary artery. So the answers are only 2, long posterior ciliary or short posterior ciliary. Now see whether it is near the optic nerve or away from the optic nerve. It is away from the optic nerve. Because it is away from the optic nerve, it must be long posterior ciliary artery. Am I clear everybody? Now let's move on to number 5 everybody. Number 5, see this artery and see this artery. Both of these arteries are piercing the sclera around the optic nerve like the bullets everybody. Yes, so number 5 must be short posterior ciliary artery. As clear as that. So what is number 6 left now everybody? Number 6 has to be anterior ciliary artery. Everybody, if you see, it is coming from anterior side and then piercing posterior to the limbus. Am I clear everybody? Done. So it is as simple as that. Just remember the theory, just visualize. The clue is optic nerve in the central retinal artery in the optic nerve. Around the optic nerve, short posterior ciliary. Away from the optic nerve, long posterior ciliary. And coming from the anterior side, anterior ciliary. Right guys? That's all about blood supply of the eye.
So guys, now that we are finished with the basic anatomy of the eye, in detail we have discussed the outermost, the middle, the innermost layer, the spaces of the eyeball, aqueous vitreous, the blood supply, everything. To complete the basics of eye, so as to say everybody, let's read in short about the embryology of eye. Embryology or the development of eye. Yes. So as soon as we start reading embryology or development, the first question that comes into our mind is, when does the development begin? So for eye, we can say the development commences at the 3rd week of gestation. At around day 21, I can say. Okay. So almost at the end of 3rd week of gestation, the commencement of the development of eye begins. Now, to understand the embryology of eye, let us see series of figures. Okay. Now, the first figure that we have drawn, this is your neural plate. Okay. Now, the central area in the neural plate that I am now marking with the dark green color, this is that part of the neural plate, everybody, which is destined to form your forebrain or prosencephalon. Okay. So, I will say this area is destined to form prosencephalon or forebrain. Alright. Now, this part, everybody, of the neural plate, this develops some elevations, as we can see. Okay. So, this has developed some elevations. Now, this central part, this will everybody deepen. This will deepen. So, deepening occurs, which leads to the formation of optic grooves, or I can say optic sulcus. So, this everybody is the optic groove or the optic sulcus. Again, I hope you can understand what I am doing, everybody. So, the part that was destined to form the prosencephalon now has started deepening, leading to 2 optic grooves. Can I say OGs? Okay. So, these are my 2 optic grooves. Remember, optic groove, this is the first sign of development of eye. When you see the optic grooves developing, everybody, then you are sure that the development of eye is taking place. Yes? Now, if you can see the green arrows, you see that the forces getting applied on this are that the peripheral part of the neural plate, everybody, is zooming in, whereas the optic groove, that part, the deepening part, is going out. So, we say the optic groove evaginates. The OG evaginates. It separates out. And we can see that the whole prosencephalon has been formed. So again, if I try to make sense of it, I hope you can understand that this is the whole prosencephalon which has been formed, everybody, which has evaginated or pinged out of the remaining neural plate. So this is the neural plate now which remains. or the neural ectoderm. Yes, neural plate or neural ectoderm. That means, if you understand, what is the derivative of neural ectoderm, everybody? The derivative of neural ectoderm is optic groove, which has now formed the optic vesicle. Very important word, everybody, optic vesicle. Okay. This is the transverse section. I hope you can see this part, everybody. This part, everybody, I hope you can see. This is shown from top, everybody, and you can see both the optic vesicles. Okay. Now, optic vesicle elongates laterally. So we have written optic vesicle lateral growth. Okay. So when lateral growth of optic vesicle occurs, if we cut this diagram, we see that the optic vesicle is elongating. This is my optic vesicle. And due to the elongation, another structure forms, which we call as optic stalk. Optic stalk is going to form your optic nerve. Later on, obviously, much later on, it is going to form your optic nerve. When this optic vesicle is growing laterally, it is coming in contact with the surface ectoderm. The part of optic vesicle, everybody, which is coming in contact with the surface ectoderm, marked with dark orange color, this is called as the lens placode. Lens placode means that is the part of the surface ectoderm which is destined to form the lens. This, everybody, occurs on day 27. Okay, I hope we are clear. If I go back at the top, everybody, I hope so that we can form a story. We know that the neural plate or the neural ectoderm has a part which is destined to form our prosencephalon. It deepens to form the optic grooves, everybody. Optic grooves are the first sign. Then this part of the neural plate, neural ectoderm, this evaginates to form the prosencephalon with lateral part forming optic vesicles. The optic vesicle elongates laterally, comes in contact with the surface ectoderm, and the part where it comes in contact is called as the lens placode. Are we clear now? So we know what is the derivative of neuroectoderm, everybody. Optic vesicle and optic stalk. The optic stalk is going to form optic nerve, and the optic vesicle should be clear enough for you if you understand anatomy. If this is my optic nerve, this has to be my retina somewhere. Yes? And the surface ectoderm is forming the lens. Now let's see how does it progress from day 27. This lens placode invaginates. I am saying LP invaginates. Okay. Now, when my lens placode invaginates, this is how it looks. It is looking as if the optic vesicle is getting a groove form inside it because the lens placode is invaginating. That is true to a certain extent. But along with this, the outer walls of optic vesicle start to grow. So what are we saying? We are saying that the lens placode is invaginating, but the outer walls of the optic vesicle are outgrowing. Yes? Now, as it moves on, everybody, we say the lens placode pinches off. Pinches off basically means it separates out. Yes or no? Yes. So when the lens placode pinches off, this is the kind of image that you get now. This is your surface ectoderm. This is your lens vesicle. And then this is your optic vesicle. I hope we are absolutely clear about this. This forms by day 33. This forms by day 33. Now, the optic vesicle, the outer margin is growing, or the outer layer is growing, everybody, as we have written. The outer wall is growing, but the inner wall is not growing. So due to that, laterally there is extension, but in the inferior part, everybody, there is fissure which remains. And this fissure is known as choroidal fissure or fetal fissure. This usually closes by 6 to 7 weeks of gestation. 6 to 7 weeks of gestation. Okay. So by day 33, the lens vesicle has formed and the optic vesicle is taking shape of a retina along with the optic cup in the center. Now, after this, let us understand, apart from this neural ectoderm and surface ectoderm, after this, let us understand the role of mesenchyme. We have discussed the role of neuroectoderm and surface ectoderm here. So now let us understand the role of mesenchyme. Mesenchyme, everybody, mesenchyme is not a layer. Mesenchyme can be derived from, I can say, mesoderm, the somatomes, everybody, the lateral port dermatome or the somatomes, or it can be derived from neural crest. Okay. Now, neural crest. What is neural crest, everybody? So, neural crest is covering the developing neural tube, and in the future it is going to form your meninges. And these meninges or these neural crest mesenchyme, everybody, this also covers the developing eyeball. Okay. So we say that the development of the mesenchyme of the eye is from neural crest. Okay. Now this neural crest mesenchyme, neural crest mesenchyme divides into two layers: superficial fibrous layer and a deep vascular layer. Okay. Now if we see this in the image, everybody, I hope you understand the image. This is your surface ectoderm. Okay. This is your optic stalk, optic vesicle. This is your lens vesicle. Now this green colored layer, this is your outer superficial, I can say, fibrous mesenchyme. And this red color, everybody, this is your inner vascular mesenchyme. Okay. This mesenchyme both come from neural crest cells. I have written NCC. If you understand the development till here, everybody, everything else should be pretty clear to all of us. Let us understand. Surface ectoderm, understand, this is going to form the optic nerve, the optic stalk. So that means this is the posterior part. So this must be the anterior part. So surface ectoderm will give us the surface, everybody. This will give us the outermost cornea, epithelium. This will give us the conjunctiva. Then we see the lens here. That means these two, the mesenchymes, have to form the other parts. So the superficial fibrous mesenchyme will form all the other layers of the cornea in the center, and in the periphery or in the posterior part they will form the sclera. Do you understand? Whereas all this red part, this is the vascular layer. So what is the vascular layer going to form? Think about it. What is the vascular layer of the eyeball, everybody? It is the uvea. Yes, everybody. So it is going to form your iris, it is going to form your ciliary body, it is going to form your choroid. The optic vesicle, everybody, it is going to form your retina. Yes, I hope you understand. This will lead to the complete development of my eyeball. If you understand it here, I am writing the derivatives, everybody. Now as I write the derivatives, I will go back to that diagram so that you understand. So let's write number 1, the derivatives of surface ectoderm. What should be the derivative of surface ectoderm? If I go back to the image, everybody, surface ectoderm is the outermost surface, everybody. So the surface of the eye, when I open my eye, is formed by what, everybody? It is formed by the cornea outermost layer. What is the outermost layer of the cornea, everybody? Epithelium. It is formed by the outermost layer of the conjunctiva. Again, what is it, everybody? Epithelium. So the first two structures I can say that will form from surface ectoderm are epithelium of cornea and epithelium of conjunctiva. Okay, no complete. Then thirdly, everybody, if I close my eye, what is the surface now, everybody? The surface is eyelid. But which part of the eyelid, everybody? Skin of the eyelids. So skin of eyelids. This is also derivative of the surface ectoderm. Remember the word surface again and again. I am saying through the development diagrams we have seen surface is the outermost part, and surface means something which you can touch, everybody. Yes, so I am touching it. When I open my eyes, I can touch the epithelium. Okay. Now, what also develops from the surface ectoderm, as we have seen, is the very important structure, everybody, lens. Yes or no? I hope we remember this. If not, I will go back to this, everybody. We saw that the surface ectoderm formed a lens placode which invaginated and then it pinched off to form the lens. So lens, even though it was an intraocular structure, or it is an intraocular structure, it has come from the surface ectoderm. It has pinched inside, everybody. Yes? Now, this is very absolutely clear, everybody. The surface of the eye formed open, closed and lens. Now, other things that you can remember is tarsal glands, or I can say meibomian gland. These are superficial glands situated in the eyelid. These are also derived from the surface ectoderm, as well as the lacrimal gland, everybody, is also derived from the surface ectoderm. I hope we have read anatomy enough as a subject in our first year or surgery, everybody. Where is lacrimal gland situated? Lacrimal gland is situated supratemporally, and it is a very superficial gland, everybody. It is not a deep gland. So we are seeing both the superficial glands, they are developing from the surface ectoderm. The surface of the eye is developing from the surface ectoderm, and obviously, everybody, the lens, as we have seen, is developing from the surface ectoderm. Now, let's move on to the derivatives of the second part, everybody. So I can say number 2, neuroectoderm. Now I think we have seen in detail the neural plate giving rise to the optic grooves, the optic vesicle, optic stalk. So we know what is going to form from it. Yes, let us see. Optic stalk is going to give rise to optic nerve. Yes, we have again and again seen. Optic vesicle which is forming is going to give rise to the retina. Okay. Now in retina, we can divide it into two parts. The inner 9 layers, so called the neurosensory retina, and the outermost layer called the pigment epithelium. All these 10 layers are going to develop from neuroectoderm. The outer wall of the vesicle, everybody, outer wall of optic vesicle is going to give rise to pigment epithelium, whereas the inner wall of optic vesicle is going to give rise to the inner 9 layers that are the neurosensory retina. Now, apart from this, everybody, what is going to form from neuroectoderm is the vitreous. Okay, vitreous is also going to form from neuroectoderm. This is very easy. I hope all these 3 points you understand through the basic development, everybody, or through common sense. What is the common sense? If I don't understand the embryology of the eye, everybody, I always say, I focus on the word neuro. Neuro means nerve, everybody. Yes. So neuro means nerve. So what is going to develop from neuroectoderm? Optic nerve. What is the neural tissue of the eyeball, everybody? Retina. Yes. What is associated with retina as a part of the posterior segment? I will say vitreous. So all these 3 things are common sense to me, either through the embryology that we have seen, development of the eyeball, or through the common word neuro, everybody here. Yes. Now, what we can learn, or what we should learn, is what are the 2 other important structures that develop from the optic vesicle, everybody. This is the epithelium of iris and ciliary body. Only the epithelium of iris and ciliary body, everybody. Apart from that, all the other part of the iris and ciliary body, which is part of the uvea, will come from the vascular layer. What is the vascular layer? The deep or the inner vascular layer formed from neural crest cell mesenchyme. Yes? Also what develops is two muscles, sphincter pupillae and dilator pupillae. These are both the smooth muscles of iris. Yes? Because these muscles have to be under neural control, everybody. That's how I can remember it. Yes? So they also develop or end up developing from the neuroectoderm, the optic vesicle. Okay? The neuroectodermal part is the optic vesicle. I hope you understand this again and again. So all this is developing from the optic vesicle. Rest everything will come from neural crest cells. So now if I say third, mesoderm. If we remember, mesoderm and neural crest cells both were giving rise to mesenchyme. Mesoderm does not contribute to formation of anything inside the eye, but what it will form are, everybody, all the muscles, yes, throughout the body. So not a part of the eye, but related to eye, everybody, the 7 extraocular muscles. Yes, there are 7. If you don't know this, watch Squint, everybody. So the 7 extraocular muscles are going to develop from mesoderm. Not a part of the eye, but related to eye. That's why we are writing it. And lastly, what we are left with is neural crest cells. So if I have to remember, I will remember it like this, everybody. Everything else, everybody, is going to develop from neural crest cells. So if you ask me, sir, that there is another muscle in the eye apart from sphincter pupillae and dilator pupillae, ciliary muscle, where will it develop from? I will say it will develop from neural crest cells. If you ask me, sir, where does the stroma of cornea develop from? I will say again, why are you asking me? It develops from the neural crest cells. If you ask me, sir, choroid develop from neural crest cells, so on and so forth. I can keep forming the list. I can keep forming the list. Everything that you can answer apart from the 12 structures that we have discussed. What are the 12 structures, everybody? 6 structures which develop from surface ectoderm. Let's revise, everybody. Lens which invaginates, number 1. Then the surface of the eye, skin of the eyelid. When you open the eye, in the center, the conjunctiva and the corneal epithelium, everybody. Then lacrimal gland and tarsal gland. 6 structures from surface ectoderm. 5 structures from neuroectoderm. Neuro means optic nerve. Neuro means retina. Retina means vitreous. Done. Neuro means muscles controlled by the nerve, sphincter pupillae, dilator pupillae, and epithelium of iris and ciliary body. 5 structures. 6 plus 5 is equal to 11. Mesoderm develops extraocular muscles, 12. Apart from these 12 answers, every other answer with your brains closed will be neural crest cells. I hope we understand this. This is, in short, your development of the eye. So now that we know the normal embryology of the eye, everybody, if we remember the structures, let us discuss a congenital malformation which has something to do with problems during the development of the eyeball, and that condition is called as coloboma. Now, this word coloboma is derived from the Greek word, again that is coloboma but just with a K, which means a missing part of something. Okay? Now, if you understand it is derived from a word which means missing part, that means in this congenital malformation, the eyeball, some part of that eyeball will not be completely formed. And that is why we are calling it a missing part. So if we say what is coloboma? Coloboma is a congenital malformation which occurs due to non-closure of choroidal / the fetal fissure by 6 to 7 weeks of gestation. So as we had seen, everybody, that there is a choroidal fissure which remains due to the unequal growth of the outer and the inner wall of the optic vesicle, then it should normally close by 6 to 7 weeks of gestation. If it does not close, everybody, the parts are not able to develop, and that condition is called as coloboma. Now, coloboma may develop in Number 1, eyelids. Eyelid coloboma. Okay. Eyelid coloboma is most commonly seen in upper eyelid at the junction of middle and medial 1/3. I hope you understand what I'm trying to say. If this is your upper eyelid and this is your nose, this is the medial 1/3, this is the middle 1/3, this is the lateral 1/3, and this is the medial. So this is the point at the junction of the medial and the middle 1/3. That is where it is most commonly seen. I hope you understand this. Let us see a photograph of it, everybody, so that we understand it better. So this is a photograph of eyelid coloboma. Both these, everybody. Both the patients that we see in the photographs. Let us see this child, everybody. If I say this is my eyelid, this goes here. And then you see a notch here, everybody, and then this. So you see that this is a part of the upper eyelid which has not developed, everybody. And that is what we are saying is a coloboma. Okay. Similarly, if you see in the other child's eye, it is a partial coloboma, but still a coloboma. You will be able to see a notch, everybody. So again, we see a notch at the middle and the medial 1/3. And again, this is a case of eyelid coloboma. Now, what is a problem which can occur due to eyelid coloboma? But think about it. If the child closes the eye, there will be a small area, everybody, which will not be able to close. Yes. So the upper eyelid and the lower eyelid, when they touch each other, there will be a small area which will not be able to close. Through that, everybody, there will be basically exposure keratopathy. The cornea, even with the eyes closed, will not be close to the environmental insult. So we say the main problem, everybody, in an eyelid coloboma is exposure keratopathy. Okay. So the main problem, or I can say the main complication, can be exposure keratopathy. Thus, everybody, I can say as a treatment, we have to give lubricants to the patient, or in severe cases, we have to do patching and at last surgical closure of defect. Whether we can do with lubrication, whether we have to resort to patching, or whether a surgical closure is required, everything depends, everybody, on the size of the coloboma. If it is a very large part which is missing, everybody, then even if you lubricate, you cannot lubricate enough to avoid exposure keratopathy. So understand, if it is a very small defect, then lubrication may hold the child or the person throughout life without causing any problem. But if it is a large one, we have to move on to surgical closures. Right, guys? Now, that is the first coloboma, everybody, eyelid coloboma. The second part where colobomas usually are seen is iris. Iris coloboma. Now these iris colobomas can be of two types. We call them typical colobomas, or we call them atypical colobomas. Typical colobomas are usually seen inferonasally. That is the most common location, and that is why the terminology typical has come. Atypical means anywhere else. They can be seen superiorly or inferiorly or anywhere else. Okay. Let us first see a photograph of iris coloboma and then we will discuss it further. So everybody, let's see this image. In this image, are we able to see some abnormality in the iris? If not, let's see. Again, I will go back to the basics. This is your sclera. The central part is your cornea. In the cornea, all this brown tissue that you can see is your iris. The pupil should have been a circle, everybody. Again, I am saying should have been a circle, but it is not a circle. Instead, everybody, what is the pupil you see? Inferiorly, everybody, there is no iris tissue. Because inferiorly there is no iris tissue, that means we are saying missing part of iris, and that is why we are saying our diagnosis here is iris coloboma. And as I said, most commonly it is found infronasally. So you will see this is the nasal side, this is the inferior side, and is slightly directed infronasally. Right? I hope we are clear about this. Now, about iris coloboma, please remember, it can be associated with colobomas of ciliary body, part of uvea, choroid, again part of uvea, retina, and even optic nerve. So these are the other important colobomas that can be seen basically. Yes, and iris colobomas usually never occur alone. They are associated with some other form of colobomas. Iris coloboma usually, again I am using the word usually, it is not the rule, but most times we see it bilaterally in both the eyes. It may lead to, iris coloboma may lead to nystagmus as a complication we are saying, or it can lead to squint, or it can lead to glaucoma. Okay, so these are the three associated ocular complications. What does the patient complain of? The patient complains of first and foremost diplopia, double vision. Why does the patient complain of diplopia, everybody? This is very easy to understand if you try to. Let's see this photograph again here, everybody. We know that behind the pupil there is lens, but the lens would present somewhere here, everybody. Yes, the lens is not going to be present inferiorly, but now the light is going through a part which has lens and through a part which does not have lens. So if you know what is ectopia lentis, or come back to this topic to understand diplopia after you have read the chapter on lens, everybody, you know that refraction here is taking place by a power of plus 16 diopter. That is the power of lens. But the refraction taking in the inferior part is without any power. So I am saying 0 diopter, everybody, because there is no lens. So the lens power is lacking. So two images are getting formed at the retina, one at the retina which is clear and one which is not getting formed at the retina because there is no power of convergence in the lower part. So the patient is experiencing diplopia. Also, the patient may suffer from photophobia due to excessive light that is going in, and another set of important problem is cosmesis. Okay, cosmetically it doesn't look good, everybody. Yes. So what is the treatment if I ask you? So the treatment can be either a cosmetic contact lens, guys, or what we can do, everybody? Obviously we can do a surgical closure with the help of sutures. We take the two ends, we apply sutures and we try to make it round again, everybody, as round as is feasible or possible for all of us. Yes, so this is another coloboma, everybody, iris coloboma. Usually you end up getting photographs of this and asked on what is it. So the missing part should very clearly indicate to you that you are looking at an image of iris coloboma. Apart from this, everybody, please remember that as I have said, there can be an optic disc or a retina coloboma also. So this is the photograph of a choroidal or a retinal coloboma, or both I can say retino-choroidal colobomas. Okay, you will be able to see that this is the optic disc here, everybody. Okay, optic disc, and below the optic disc, everybody, inferior, there is this whole excavated look of area, and this is your retinochoroidal coloboma. Okay, I hope we are able to understand this and there is no confusion in this very small and short topic. Basically, you're primarily an image based. First you have to recognize the image of all the three colobomas that I've shown to you, and then based on that you can be asked questions. As a last point about coloboma, I will make a star, everybody, and write lens coloboma is not a true coloboma. That means what? That means that sometimes when we look at the lens, we see that some part of the lens is missing. Instead of being a biconvex shape, so there is a notch in the lens, everybody. And as soon as we see that, we think it is a missing part of lens and we call it lens coloboma. But even though it looks like a coloboma, it does not develop due to the non-closure of choroidal or fetal fissure, and thus we say it is an association due to non-development of iris, due to non-development of choroid and everything. The lens also does not develop completely, but it is not due to the non-closure of the choroidal or fetal fissure, and thus it is not a true coloboma. Yes, I hope we are pretty clear with this, everybody. With this, I end my complete discussion that I can do on the basic anatomy, everybody. And that is the word I need all of you to focus on: basic. That is what I have harped for the past 4 hours. I have taught you enough anatomy here, everybody, more than enough probably, to make you understand the importance of basics. If you don't understand the basic knowledge, whether that be about the layers of the cornea, or whether that be about the fact that cornea is transparent and iris and pupil give the cornea the color that they give everybody, everything moving ahead becomes difficult. Apart from the understanding, as you have seen, there can be thousands of questions which can be asked, whether we are talking about the site of intravitreal injection, whether we are talking about the routes of ocular drug administration, whether we are talking about as simple as what maintains the transparency of the cornea, or why is limbus important, right? There are lots of questions. I hope you give it enough time. You start reading everything from the basics, and that is the thinking, that is the soch behind what I teach, that we are able to comprehend and understand and not just have a rote learning, guys.